guidance in a hospitalized child. Now, what does that mean? That means that you want to give your parents some kinds of information that will help them weather the hospitalization. So you're going to have to be able to synthesize based on what you know about each age group, psychosocial development, where they're at, what a parent's involvement is with the child's life, and be able to answer a question like that. All right? Know what they're going through, know what the kid's going through, what the family's going through, and what is your job as a nurse to help them with that. Anticipate different types of families. I talked about that the first time I met you. There's blended, there's single, there's all different types. You should know the definitions between the two. So, anticipatory guides for each age group was listed in each chapter. There are different things that we pointed out. So one of the big headliners is safety. What does that mean for each age group? Anticipatory guidance can also be what to expect your 3-month-old to do, your 4-month-old to do, in terms of growth and development, in terms of physical development. And that anticipatory guidance basically helps the parent keep an environment that's safe for the child. It also makes them understand what a child is doing and what is the child capable of doing. If you were to get an example of a child eating steak at 6 months of life, somebody missed the boat on anticipatory guidance, right? Solids aren't given until after 6 months of age, and then it's pureed foods, and then they graduate, right? So those kinds of things. Child abuse or non-accidental trauma. What is the nurse's responsibility? Just like anything else, you need to bring it to somebody else's attention so they can assess it. That does not mean you call the police and say, this is child abuse. If you see a constellation of symptoms as a nurse at the bedside, a nurse in the clinic, and you are concerned, you bring your findings to someone, sort of like the SBAR, and say, I saw bruises on the buttocks and on both knees, and this is what I got in the health history, and I just wanted to bring it to someone's attention. You don't need to add, and I feel this is child abuse. Okay? We get all sorts of cases where we get told it fell from a 2-foot changing table to a, off the bed, and we got a femur fracture. All right, well, okay, I don't know. Maybe this week the first kid that I see who's 2 months old falls 2 feet, gets a femur fracture. I don't know. Okay, but I just give the data the way I see it. But the most important thing is to bring it to someone else's attention, your concern, that does this add up to something, and should we investigate with our own investigation, right? But it's not pick up 911 and call the police, right? I mean, unless you're like a kid comes in a gunshot wound who's bleeding out, or something like that. Yeah, I mean, circumstances, right? Stranger anxiety is something that we see in children basically at the ages of about 7 months. Basically, they're used to, remember, the brain processes, right? And they're used to familiar people. That's their trust. When we put them with unfamiliar people, nurses in the hospital, they tend to protest and cry and want to be with that person. We have to figure out creative ways on how to minimize stranger anxiety. One of the examples I gave about 15 minutes ago is what do we do in the hospital? What's in every hospital room? In Children's Hospital? We do rooming in, right? So we try and make it as easy as possible for the parents to stay with the child. At Suburban Hospital, if you admit a kid to our short stay unit, it's a mandatory that a parent stay with the child. They're not allowed to be. Now, it's for a lot of different reasons, but one of them is to avoid some of the stranger anxiety. But stranger anxiety can happen when you're at your family reunion and you want to hold your sister's 7-month-old, and they don't want you to hold it because they're that stranger anxiety. Okay? So again, it can happen everywhere. It's just a normal phenomenon of things. Remember that stranger anxiety can happen all the way up, possibly through school age. Kids will not want to be with anyone but their well-known caregivers. So they'll create stranger anxiety depending on what developmental level they're at. Okay, safety issues for all ages. Anticipatory guidance you give to parents of a toddler, of a school-age kid, of a adolescent, right? What would be anticipatory guidance for adolescent that you'd want to come to? It's in the heads exam. Anticipatory guidance on drugs, alcohol, sexual contact, right? Take it even further, driving, okay? Things you'd want to take for a toddler. I would say poison ingestions might be something to think about because they're into everything. They can move around. Typically, we think that toddlers are the number one poisonous ingestions by accident. What do you think it is? Geriatrics. They accidentally take too many of the wrong pills, the wrong amount. So if you're supposed to take 2 of the green pill, and you got it refilled, and the green pill now is ×2. You got 2 pills with green, and you're only supposed to take half of the green pill. You take 2 of that green pill, you got yourself an accidental ingestion, right? Okay, do I need to say anything about number 7? You will see synthesized questions that you should be able to answer based on these levels, okay? Normal growth and development at each stage. General terms, what should a toddler be able to do? Infant. I spent a little bit of time talking about temperament. Parent asks you how to deal with it. If you read that section, you'll get some really good advice. Talked about cephalocaudal and proximal distal. Denver developmental screening tests. Screens basically keeps an eye on kids who are at risk for developmental delay, or already have some. Anterior posterior fontanelle, talked about, parasynesthesis. All right, way back in the day, I did talk about informed consent and the general aspects of informed consent. It doesn't mean that the parent, because with all children except for emancipated minors, right, informed consent goes to the parent under the age of 18, right? But remember that informed consent is really that you are consenting to the information you got, right? That it's been explained to you. Not exactly consenting to the surgery, you're consenting that you've been informed that someone is, you've consented to that information given, right? So you want to look at that. When you get, parents give you a symptom, what's the best next thing to do? You'll get a lot of these questions. You get a lot of your instructors telling you, oh, you know, when a patient goes into cardiac arrest, you have to do all these things, and you feel like you have to be doing all these things at once. Well, number one, there's a lot of people around you that are going to be helping do all those things at once. 2, we always have to remember what's the next best thing to do. On your exams, without fail, HESI, NCLEX, whatever, always think of, is the airway secure? So it's airway, breathing, and circulation, or whatever the question may help you answer it that way, all right? So the safety of the patient is what you're getting certified to do, right? So they want to know that when you walk into somebody with altered mental status, you're going to make sure that they're breathing okay, and they have an open airway, and that you've assessed their circulation. You've got some data on which to act, right? It gets really that simple. The safety of the patient is what we are certified as RNs to do. So to think of the questions that way. Now, the next best thing to do when you get a symptom, I always think, is to get more information. Don't act on one symptom. See if you can get more information. So, for example, this weekend, I took care of a kid who came with seizures, and we did an MRI, and has some kind of weird thing in his left brain. And so, my job was to extubate him because he was intubated. So, but they had to replace an EEG to look specifically at what they found on the MRI so that maybe they could collaborate findings of the MRI with the EEG as possibly the seizure focus, and then that would help them then delineate what kind of seizure meds they get. So I'm explaining that to the parent how I'm going to take, once he gets a lesion on, we're going to extubate him, and we're doing another EEG because we want to do this. And Dad goes, oh, similar to what I had? I go, what do you know? He goes, oh, I got something in the left side of my brain. I go, did you tell the neurologist that? He goes, no, they didn't ask me. Okay. And then I said, well, how do you know that you have that? He goes, well, you know, I just had on my routine physical exam when I was 7, I had a CT scan. I go, first of all, no one gets gets a routine CT exam. He goes, well, I did. And he's convinced that everybody should get a CT of their head when they're 7. So people just take away different information. So I see the neurologist the next day on Saturday, and I go, did you know father has something going on in his brain and he's being followed by a neurologist? No. Who told him? Who said that? And I said, you told me that yesterday. And I was explaining the MRI. Still tight. Okay, nurturing parental relationships. So you're going to see in a primary care setting with Peds and in a hospital, you're always going to be looking at how the relationship is with the kid to the parent. And you need to be able to assess that, because sometimes it might bother you, and sometimes you're going to know that it's adequate. And that's what you need to know. And so you need to look at signs and symptoms that will tell you that this is a negative or positive parental situation. Now, dads or moms who are not with the child a long time, it's like adopted kids who come in and they're really sick and they were just adopted 3 months ago, and the parents kind of fumbling around. Well, they just don't have bonding yet, right? I wouldn't hold that against them, but you look for how the parent is meeting the cues of the child, right? Okay. Temper tantrum guidance to parents. I didn't give you a lot of this, but it's in your book in that section of toddlers. Temper tantrums, there's like a 3-step process. Get them out of the stimulation, calm them down, all that kind of thing. So I would say look at that. Self-esteem in all ages and how parents can help develop that. So it goes with psychosocial development. Knowing when your parent hasn't mastered information and a procedure that you need them to know. We always want to say that we show one, we let them do one, or we teach one, and we let them do one as a way of mastering a skill. So that's kind of the concept we're looking for here. Toilet readiness, there's a book, there's a little table in there, once the kid's ready. Gross and fine motor movement. Spend a little time on gross motor movement. And the infant assessment, we're looking at fine motor movement. The classic one is the pincer grasp that we see at 10 months of age, where they pick up the Cheerio or the little thing with their fingers. That's fine motor movement. Sticking their hand through a keyhole is fine motor movement. It's not gross motor movement, right? Knowing the differences. Sleep and nap patterns for all age groups. Remember that infants can sleep up to 20 hours a day. We typically drop, they have then move into infancy with 2 naps a day. And then, when they become toddlers, we try and have them drop a nap. Now, if you want them to sleep through the night, which nap would you have them drop? Would you have them drop a morning nap or the afternoon nap?
Afternoon.
Obviously, some of this is common sense, right?
Mm-hmm.
All right, good. Sibling rivalry, advice for parents. Obviously, this is common sense too, but there's a nice section in your book. Leading death in each age group is trauma. Trauma, and trauma. Now, trauma could be poorly restrained in a car, walking across the street. I don't care, it's trauma, all right? Oral hygiene and toothbrush. I already told you how many up and how many down by the time they're 2. 10 up, 10 down. First visit ought to be probably 2.5 months, I think the book says. But parents can be washing the gums with a soft washcloth in infancy. Nightmares versus night terrors. Remember, nightmares are long, happen at the end of REM. Night terrors happen at the early part of REM. So all kinds of night sleeping patterns that are classic for the toddler, late toddlerhood, and how each parents deal with it is important. Physical growth, we talked about a lot. Okay, there's Piaget one more time. You should define egocentricity, perioperation, and formal operations. And an example, there are different types of play. Remember, there's most simply just playing, and there's parallel play or solitary play, parallel play. They're not playing together, just playing side by side. And there's group play. Group doesn't know anything about that. Ethnicity and culture and race, how they affect the child. Remember, some children are psychosocially differently raised than other children. So, for example, some cultures may not put their kids in school until 1st grade. Well, they're going to have a rough time on the first day, aren't they? So, that's a cultural thing. Tanner staging, I agree with page 108. Colbert, I agree with page 116. And there will be calculations medications, I like to know that you can figure out what the difference is between kilos and pounds, cc's. I like to know that you know your ratios. Not a lot of them, but some of them, okay? Because if we goof up in kids and we give too much, you can't take it back. So I like to do that all along. So you will see calculation problems on every one of your exams. Okay? Enough?